So the first patient is a 69-year-old male with malignant ascites and pleural effusion and with the primary unknown. So this is, I think this is from the ascites. So in this specimen, we see some cell cluster in three-dimensional architecture. The cells are pronounced atypia and polymorphism, and a little bit of necrotic, like individual cell necrosis in the background. So because it's a male, it's in the abdominal cavity, so the first guess would be from the GI tract or the pancreatobiliary tract. So the patient also have a cell block preparation. Again, there are similar cell cluster. So Dr. Shi has ordered a couple stem. TDF1 is negative, and CDX2 is positive. So it is compatible with GI tract origin. But if you take a look at the some of the typical cell is actually negative, so it is not very diffusely positive. I think in the background there were more carcinoma cluster, and there were just a few positive, but strongly positive for CDX2. So Dr. Shi also ordered CK7 and CK20, which we rarely use in the pleural effusion or the other body cavity fluid, such as ascites, because it can stand with the background mesothelial cell. So this is CK7. We only see individual cell. We didn't see cell in cluster. This is CK20. We see more cells. Some are actually in cluster. So probably in this sense we can say that, okay, the tumor cell might be positive for more positive for CK20 instead of CK7. But to me, I think in the background there were more cluster than what we see in the CDX2 standing. So it is a little bit difficult to interpret. So I turn to only use lineage specific marker in the cell block for the pleural effusion. I rarely use CK7, CK20 to differentiate the origin. So this is positive for CDX2 and is likely from the lower GI tract because it seems to be also positive for CK20. So this is the second patient is 49-year-old female, so relatively young still, and it's from the ER department, and this is the pleural effusion specimen. So on low power, we see a lot of individual cell with a very monotonous like appearance. In the background, it seems to be not so many inflammatory cells. So when we get on higher power, we actually see that almost all the cells have nuclear atypia, which include vesicular chromatin, irregular chromatin pattern, and some with the nuclear, although it's not very big. And there were also a couple interesting cell arrangement that we see. The first one is what we call cell-in-cell pattern. So you can see there is a cell wrapping around the other cell. This is called cell-in-cell. The other is what we call Indian fire. This is an Indian fire. Okay, So the rest of the cell seems to be more in the dissociated individual cell type. So again, we see cell in cell, we see Indian fire. So these two patterns are very common in the metastatic breast cancer. So the patient indeed had a history of breast cancer. So in this specimen, I would say more than 90% of the cells are tumor cells, almost approaching to 100. So all these cells seems to be tumor cells, and I guess it can be ductal because we still see some arrangement, but we also do see a few like signaling ring cell type cell make us thinking about lobular carcinoma. The patient has ductal instead of lobular. So these arrangement pattern is kind of will be present in both the ductal and the lobular carcinoma. Okay, so if we take a look at the cell block again, we see quite prominent cell-in-cell pattern. It is an interesting pattern. And we didn't see a lot of Indian file here. Yeah, but this is the patient of breast cancer, non-breast cancer history. The second specimen, we've seen this case before. The patient has been diagnosed with squamous cell carcinoma in the lung, but she is a 71-year-old female, non-smoker. So we've seen her prior pleura effusion, and we confirmed it is adenocarcinoma with CTF1 expression. And then we go back to the prior bronchoscopy biopsy, and then we can see a minor adenocarcinoma component in that specimen. So the patient is actually had the adenosquamous cell carcinoma, and the squamous component is likely derived from the adeno with transdifferentiation, and the patient do have EGFR mutation. Okay, so the treatment can be quite different from the original diagnosis of squamous cell carcinoma to the revised diagnosis with adenosquamous cell carcinoma with EGFR mutation. So the patient in the pleura effusion specimen still have only adenocarcinoma component, so which also tell us the cell morphology is really important when you had a history of squamous, but you see it looks more like a adeno in your cytology specimen. You need to work it out. And sometimes, because the biopsy histology is only sampling, so sometimes they can miss a significant component in the biopsy specimen. So this is also an important message. So the next specimen, again, we've seen this one before. So we see these quite atypical mesothelial cells, also with these like oranginophilic cells. Sometimes it can have a little bit Indian fire pattern as well. I would say the mesothelial cell here is very atypical, right? The nuclear contour is very irregular. You see a notch over here, and you can see prominent nucleoli. We didn't see a lot of cell clusters, three-dimensional arrangement, but we have done quite evaluation for this patient. This is a mesothelioma patient, and the cell block demonstrate loss of Merlin and the MTAP. So this is from the same specimen of this 30-year-old young male. So this is again mesothelioma. So the next specimen is from a 79-year-old female. This is a ascites specimen. The patient had a past history of pancreas cancer. So here we see some really high grade, like adenocarcinoma cell in tight three-dimensional cluster. The cells are markedly enlarged with prominent cherry red nucleolus. So this is positive for adenocarcinoma, and it's a high-grade adeno, so it can be compatible with the pancreas cancer. Okay. So the next specimen is also a rare condition. This is from the abdominal cavity. So again, on low power, we see a lot of individual cells with a very monotonous appearance. And on low power, you can feel the nuclear staining pattern is more hyperchromatic. On higher power, again, we see a lot of individual cells, and most of them seems to have eccentric, like a Sigourney ring cell type of pattern. You can see some mucin over here. Like this is quite a typical cell with a prominent nucleolus, and it is eccentric. The shape of the nucleus is angulated. So it looks like a Sigourney ring cell adenocarcinoma. Most of the time, when we see these in the ascites specimen, it is coming from the stomach. However, the patient actually has been diagnosed with Sigourney ring cell adenocarcinoma arising from the urinary bladder. So this is very rare. I actually diagnosed the case with the bladder biopsy 4 or 5 years ago. Yeah, so it has a recurrence of the Sigourney ring cell carcinoma, and because of the prior histories, the origin is the urinary bladder. So this is coming from the bladder instead of the stomach. So this is positive for Sigourney ring cell adenocarcinoma. It is most likely compatible with the patient's non-history of bladder adenocarcinoma. Okay, so we move to a couple fine needle aspiration. So this is from the pancreas. So we do see a lot of cellular component. When you get a lot of tumor cell, it is quite easy. Sometimes for the pancreas aspiration, the tumor component can be really scant. So sometimes you really need to correlate with the clinical finding, including the serum tumor biomarker, as well as the image. And it's important to do the biopsy correlation. For these specimens, the tumor cells are just plenty, so it is easy that we can call this adenocarcinoma. In the same patient's direct smear, again you can see this is a desmoplastic stromal component, but in the background, wait, 是 哎，有，好，可能快一点，因为我在开会。嘿，对，3天是什么意思？对，上礼拜5传的，可是那为什么我昨天才收到？对啊，诶，好，没关系，好，谢谢。So I think in this direct smear, most of the components are benign. So it is important to recognize the benign pancreas elements. So these are all benign acinar cells with a nice acinar arrangement. So which is kind of different from the prior liquid-based specimen. So this is from different paths of aspiration. Sometimes you get most of the element is actually benign. There were only one cluster of these markedly atypical adenocarcinoma component. So this is we see only one cluster. So sometimes it's difficult because it's easy to have contamination. So the next specimen is the CSF specimen. So in the normal CSF specimen, there is no cell. Sometimes we can see if it has meningitis, we have a lot of inflammatory cells. The patient has, again, breast cancer. So you can see this is Indian fire pattern. So this is positive for carcinoma. So this is a thyroid aspiration. So in the background, we didn't see a lot of colloid. And we do see some tight cell cluster. And this cell cluster seems to be the aggregates of multiple micro follicles. So we have microfollicular like arrangement with very, very scant colloid. So again, here you see tight cluster of microfollicles. So this is diagnostic for a follicular neoplasm. This is the patient's second aspiration. The first one we call AUS with architecture and the cytologic atypia. So you can appreciate some of the cell has a little bit enlarged of nucleus. But in this specimen, we actually didn't see more prominent nuclear features suggesting it's a PTC. So in this specimen, we call this TPS4, suspicious for follicular neoplasm. Finally, let's move to the pap smear. So this is a 47-year-old female. So possibly at the age is perimenopausal. And in this specimen, we do see very scattered tight clusters of degenerative cells and with prominent phagocytosis. So these one seems to derive from the endometrial cavity with marked degeneration. And you can see there is one very prominent atypical cell with very irregular nuclear contour and a very irregular prominent nucleolus. So this seems to be a typical glandular cell component. In the background, we actually didn't see a lot of endometrial debris. We only see these tight cluster of atypical glandular cells with a prominent phagocytosis. And in this tight cluster, it is very convincing that we see highly atypical cell cluster. It's already exceeding the atypical cells, but I think this is diagnostic for adenocarcinoma, and they do have cytoplasmic vacuole full with the PMN. So we call this pattern bag of worm. So this is a typical bag of worm pattern in endometrium derived, sometimes in the endocervical, but most of the time in the endometrium atypical glandular cell. So this, I think it is okay to call this adenocarcinoma. But again, in the background, we didn't see prominent endometrial debris. So for the endometrial cancer, if it is estrogen associated, such as endometrioid adenocarcinoma, it is very common that you can see the endometrial debris. If it is a different type of endometrial cancer, such as serous carcinoma, sometimes you only see prominent high-grade atypical cell. So again, this looks a little bit like exodus. Yeah, it looks a little bit like exodus, but it's more inflammatory cell infiltration, right? So it's probably not a classic example of exodus, but there's lack of the background. So the patient already received the surgery and it is diagnosed with the serous carcinoma in the endometrial cavity. Yeah, so it is not so common to see. And the pap smear is before the surgery. The next specimen is from a 32-year-old female, and she had the HPV test with the high-risk HPV positive. So since we start to perform the HPV test, we have more cases that we already know the HPV result before that we have a cytology interpretation. So when I was in the States, I always consider this as cheating. But when we actually have these like a practice like a setting, I think it is important to know that the prior HPV status. So for these, I think the cell is very, very tiny. If we want to call it ASCH, it's a little bit too much. I still believe that it is possible, like histiocyte, because it doesn't have a very squamous, like a dense cytoplasm, etc. It doesn't have a very dense cytoplasm, suggesting it's a squamous cell. But here, I think this is okay for ASCUS. So sometimes we already know the HPV status, so we will look very carefully, and we might consider to call these ASCUS. If we don't know the HPV status, possibly we will just call this reactive. But if we know it now, it is possibly safer that we just call it ASCUS. So I think for these cases, it's okay to call it ASCUS. The ASCUS high is a little bit too high, I think. Yeah, but we do have a couple cases that is totally in the pap smear is totally negative, but in the corpuscle biopsy they do biopsy a high CO region. Okay, so this is also a typical squamous cell. Yeah, it's mostly superficial. So I think it's okay to call it ASCUS. And for our clinician, if we call it ASCUS, sometimes they will just do a colposcopy biopsy because they already have the HPV information. So this one is also an example of a non-HPV status with high-risk other type and with concurrent pap smear. I think for this specimen, yeah, again, so we can see a few atypical squamous cells. This is possibly nothing if we didn't have the HPV status, but if we have it now, it is okay to call it ASCUS. I think the ASCUS is fine with these cells. are some naked nuclear, so we cannot make interpretation of these type of cells. There is a large fragment. This is likely at the metaplastic squamous metaplasia, but we do starting to see polymorphism and more coarse chromatin. So I think this is approaching to the high CO, but it is not very definite. If we see a few mitosis, possibly we would be more comfortable to call it high CO. So this large fragment is very strange looking, and there's one tiny detached component. Got a little bit glandular arrangement, but I think the chromatin pattern and the overall appearance is still more toward to the squamous. So it is important to distinguish squamous and the glandular. So the Cytotech call it a typical gland, but it's actually at the metaplastic junction. So I think it is okay to call it squamous. So for this case, I think it's qualified for call it Ascus high. Okay. So we don't have a lot of cells, only these larger fragment and a few detached one, but it is okay that we call it Ascus high. So the nuclear feature you can definitely see is more prominent than the prior specimen. So this one we call it Ascus high. And finally, we have a real unequivocal high CO case. So the patient has been diagnosed with low CO for a couple times. Okay, so for these, we see one atypical cell with high NC ratio, but the nucleus seems to be very degenerated. Okay, but the NC ratio is high. So here you start to see these cluster. It's definitely squamous cell. It has superficial cells, also with relatively high NC ratio. But these intermediate cells, you can see, it is very high NC ratio, and the chromatin pattern is very coarse and hyperchromatic comparing to the adjacent benign cells. So this one is actually qualified for the precursor, and because we have the high-grade, high-risk intermediate cell as well as the superficial cells, I think it is okay that we call these CIN2. So the patient last year we had two pap smear, both of them we call it low CO, and in this year it start to progress from CIN1 to the CIN2. So this is more than CIN1, more than low CO, right? Probably if you only see these, we can call it low CO because it still maintain a relatively low NC ratio, but because of these two guys, it is CIN2. So this is a more definite diagnosis of a precursor lesion. So we have Ascus high, we have these CIN2 cases for today. Okay, so this is the case for today. So I wish everyone a happy new year.